Thanks very much. Again, I'd like to thank the organizers for inviting me to speak here. I'd like to offer in this presentation a few remarks and my perspective on the microeconomic impacts of treatment as prevention. And here's an outline of what I'd like to talk about. First, I'll start by defining what I mean by microeconomic impacts, and then I'll move on to telling you about research that my colleagues and I, as well as other groups, have done on measuring the economic impacts of HIV treatment as it's been provided so far in resource-limited settings, primarily sub-Saharan Africa. And that'll provide a good framework for thinking about what the potential, and when I emphasize potential here, as I'll describe in the presentation, potential microeconomic impacts of treatment as prevention might be. And I'll offer finally some implications for implications of that for aggregate economic impacts, hopefully without taking away from anything David has to say afterwards. All right, so the basic motivation for a lot of this research comes from this expectation we have that health improvements ought to influence both individual as well as household level socioeconomic outcomes. So a fairly non-controversial premise. But we want to use available individual and household level data to actually quantify what these impacts are. And typically we have in mind outcomes such as the employment and income, as well as economic investments that individuals and their families are making, and also keep a focus on other household members who may be affected by HIV, or the presence of an HIV positive adult in the family. And we'll look at outcomes such as child labor or children's education. And I want to argue here that measuring these impacts is important for a couple of reasons. One, and this echoes some of the comments that Joop had made a couple days ago, is that this tells us a little bit about what these non-health or secondary impacts of investing in health, HIV treatment is a good example. What are those non-health impacts? And then I'll also make the case that these are actually important for getting a sense for what the aggregate community or provincial or national level impacts might be of investing in HIV treatment. And just a caveat for all the results and arguments that follow is that the micro focus does miss several types of impacts that may well be important. So it's not focused on fiscal implications or even impacts of HIV treatment provision on health systems, or even for that matter, in some settings, you may imagine that firms or employers may stand to benefit from having a healthier population. So that gets neglected when we look at this very micro, we take this very micro approach. And then just briefly, the other rationale for quantifying these microeconomic impacts is I would argue that a lot of the evaluations we have of HIV treatment have often focused on two important factors. One is obviously the health impacts, so understanding what HIV treatment expansion means in terms of life years saved or population life expectancy, mortality, obviously very important outcomes. And then the other is program level costs, which again is important if we want to figure out what are the ways we can, how can we do things in the least cost possible way. And these are necessary inputs for cost effectiveness analyses. But the argument here is that these analyses do miss some important benefits that are actually essential if we want to do a proper cost-benefit analysis of an investment. So understanding what the impacts on other economic outcomes might be can really get us towards that cost-benefit analysis that we want to do. So turning to then the existing evidence base on what happens once you initiate HIV treatment at the microeconomic level, I'll start by looking at the employment status of the individuals who are getting treated themselves. So there are quite a few studies now that over the past 5 to 10 years have emerged, and they've documented very well that employment responds very rapidly and in a very significant way to the initiation of HIV treatment. Not a very surprising result, but in some sense the scale of the response is quite impressive. So this is a study from Kenya that my colleagues and I conducted. On the left-hand side, you see a very typical health response to the initiation of HIV treatment in adults. And then on the right side, you see what happens to participation in the labor force. And remarkably, it mirrors, in almost an identical way, the health response to HIV treatment. So telling us that there is this very tight linkage between health and economic status in these resource-limited settings. Another nice study which takes a much longer view, recently published by Sidney Rosen and colleagues, looks at patients receiving HIV treatment at 3 clinics in South Africa, and again shows in red you can see that the proportion of patients participating in the labor force who are actually employed, that rises from about 30% to nearly 45% over the 5 years, so it's a sustained increase. And at the same time, for those who are employed, there's a remarkable decline in people who report having difficulty performing their work or are unable to do their normal activities. So these studies, and these are just 2 out of many that have shown a very consistent pattern of increased employment and economic status in households of patients receiving treatment, are one part of the story. The other is something that emerges when you take a look at the households of the individuals who are getting treated. So we know that the individuals getting treated are doing better. This study, which is again based on results from the work I did in Kenya, shows you what happens to children residing in these households of adults getting treatment. And in red, you see, again, a sustained increase in employment for the adults getting treated over a period of 3 years. And in green, what's remarkable is that the labor that's reported for children residing in those very same households is declining, almost in a kind of an opposite manner. So it does imply that households, when faced with the health burdens associated with HIV, do rely on children to provide labor, and that is diminished, that need for labor is diminished as adults are getting healthier and going back into the labor force. And child labor is one part of, one outcome that we could look at for children. You may wonder, well, what are they doing with that time if they're working less and less as the adults get healthier? And the answer is that they do seem to be spending more time in school. We're seeing evidence of improved nutritional status in those children because there's more income in the household. And others have also spoken of the averted end-of-life expenditures as a result of treatment provision. So far I've summarized evidence on what happens to patients and their households, what happens to their economic outcomes once you initiate treatment. But it's worth keeping in mind that in almost all of these studies, patients are initiating treatment at CD4 counts well below 350 even. And it's perhaps not surprising in that case that given what we know about the dramatic health response to HIV treatment, that these economic impacts are also occurring. But if we want to move towards thinking about what the microeconomic impacts of treatment as prevention or early treatment are, I should start by saying, one, we don't have the set of studies that would document as convincingly what those microeconomic impacts are, but that work is actually underway now. But we can get a sense for what these benefits might be, and I'm going to argue in the next few minutes that these benefits may very well lie in preventing the economic decline from taking place at all, and instead of necessarily restoring the economic status. And I'll motivate that by a study that my colleagues and I in the SEARCH study in Kenya and Uganda have done. This is using pilot data from the SEARCH study and asking the question, what is this association between CD4 status of HIV-infected adults who are not receiving treatment and have just been diagnosed and employment outcomes? And what we're finding in Uganda, at least in this one pilot study community, is that there is a significant association with CD4 and employment, and remarkably, even at high CD4 counts, starting from high CD4 counts, we start to see declining employment levels as the CD4 is lower. And this is one study that suggests that initiating treatment early may actually help avert the type of decline in employment that we're finding with CD4 count. Another study, which is based on data from the Africa Center cohort, also is providing results that are very consistent, or largely consistent. And here we see that if you look at a cohort of HIV-infected individuals 8 years prior to initiation of treatment, they do have much higher employment levels. And it's the period 3 to 5 years before ART when you really start to see the decline taking place. So perhaps not evidence of an economic decline as early as suggested by the search data in Uganda, but still evidence that initiating treatment early may help avert this economic decline. So then what are we left with is a schematic of what the current evidence base is, and this shows us that if you take an economic indicator like employment status, the decline starts to happen soon after HIV infection, and then once you initiate treatment at low CD4s, we see a rebound. And then this would be then the case for potential microeconomic impacts of treatment as prevention, is that we're potentially averting the entire dip from taking place at all. And for employment, that's a powerful argument in terms of being able to avoid the employment decline, but I think it's more powerful when you think about the same thing happening for children's schooling. Because if you have a dip in children's schooling where they actually drop out of school, you may not see that rebound take place. You may see some rebound in attendance, but that's a much longer term impact of initiating treatment early. So we're doing right now several studies. The SEARCH trial in Uganda, which I'm involved in, is a cluster randomized trial in which some communities are receiving treatment initiation immediately after individuals are diagnosed, and in others it's the standard of care. And there we're going to be able to look at, using an experimental design, what are the economic impacts of a test and treat strategy, and we're going to look at outcomes that range from employment and education to also investment behavior. And that's one study which should provide us with some rigorous evidence on the microeconomic impacts of treatment as prevention, and I would expect that other studies that are ongoing are also looking at similar indicators. And then a final point then is in thinking about what does this mean at the national level. It's worth pointing out, almost all the studies have looked at the impacts on treated adults and their households. And that's been the case for the ART studies that I showed you just now. But at the regional level or national level, or even you could argue at a smaller community level, the impact of treatment as prevention alone, it may not translate necessarily into a large impact economically. And that's because of two reasons. And one is that it could just be that you're looking at a community where prevalence is not extremely high. So this might exclude southern Africa or certain parts of Kenya in the Great Lakes region. But in other places where prevalence is 7 to 8%, even a big economic impact for the individuals and households who are HIV infected doesn't necessarily translate into a big community level impact. And so where we have to also be looking at what's going on is the responses of individuals who are not HIV infected, and what are the economic impacts there. And I would argue, on the basis of a few recent findings about the very large gains in life expectancy as well as reductions in mortality due to ART, that it may well be that among HIV uninfected individuals there are sizable microeconomic impacts. So we may imagine increased employment taking place due to mental health improvements in HIV uninfected individuals, or increased economic investments as entire people in the community have longer subjective life expectancy. And there is some evidence that's emerging that this type of behavioral response is taking place. So in conclusion, based on the existing evidence base, I think there are strong reasons to expect that treatment as prevention may result in improved economic outcomes. We need more data from ongoing trials to really confirm that. And we may find a sizable benefit at the community level if there are significant behavioral responses in HIV uninfected individuals. And I think in the end, we may be able to arrive at a more comprehensive cost-benefit analysis that's needed. Thanks very much.